Thank you, Jan, and it's a great pleasure to have you here, and I would like to thank my good friends and colleagues from the ΜΗΤΕΡΑ Hospital, Aphrodite Zifa, Fotis Mitropoulos, and George Saris for inviting me to this excellent symposium of congenital heart disease and pediatric cardiology. And I would like to thank you all of you for being here on Saturday morning. My topic is to talk about the use of defibrillators in children less than 16 years of age. Is it not necessary, or is it underused? And I would like to say that my task has been made easier by Dr. Avramidis, who showed some of the aspects of the problem. So I would focus more on the ICD aspect of the discussion. Now, the problem here is we have always been concerned about how to prevent sudden cardiac death in children, which is, although rare, it is tragic. And we now have more often this situation of patients who are resuscitated from an arrest, or who are diagnosed in a pre-participation screening, and then family screening reveals more carriers, either with genetic testing or with ECG or other modalities. And we don't know often what is the best way to manage these patients. Should we put an ICD prophylactically? Should we keep following them? Should we give medications or other therapies? And one more significant aspect of the problem is that the side effects of an ICD in a young patient are considerable, and sometimes they surpass the benefits of the ICD in young patients. Here are some various ways of putting an ICD. In the classic ways, the transvenous ICD implanted in the right ventricle, but we also have in young children the option to put an epicardial defibrillator coil with ICD in the abdomen, or even intrapleural coil. And in the most recent version, the ICD can be implanted extracardiac and extrathoracic place, with a device placed in the lateral left chest between the serratus and the latissimus dorsi muscles, and the coil in the parasternal subcutaneous space. So the question is, are the defibrillators underused or not necessary in young children? Of course, we do not have accurate data regarding pediatric deaths that could have been potentially prevented by ICDs. And data regarding ICD efficacy and complications are available for certain conditions, but include few patients less than 16 years of age. There are only case reports in small series of young patients treated with ICDs for rare conditions. And on the other hand, we have the potential use of other measures like pharmacologic and lifestyle changes to delay the procedure until an age when fewer potential complications and technical issues are expected. A recent study from Europe showed that, of course, we got what we knew already, but in a more systematic way, that epicardial ICDs have higher rate of complications, both from leads and ICD, and higher rate of reintervention. There is a mistake here. The blue is the epicardial, the red is the transvenous ICD. So you can see that in all aspects of these ICDs that are placed intrapericardially or epicardially have higher rates of complications over the next few years. So here are a few situations where an ICD might be needed in children and adolescents. The first group in the green line is the genetic arrhythmia syndromes, which Dr. Avramidis talked about, then cardiomyopathies, and repaired heart disease, although this comes usually at a later age. And then there are some other diseases that usually do not require an ICD for treatment, and we can manage either with a catheter ablation or with surgery. One of the most common ones, of course, as Dr. Avramidis talked already, is long QT syndrome, which is found in about 1 in 2,500 patients. It has two types, the autosomal dominant and the autosomal recessive type, the second one being most severe with congenital deafness and higher rates of life-threatening events called the Zerver-Lange-Nielsen syndrome. Here is a slide that Dr. Avramidis showed that shows the various ways of long QT presentation with long QT type 1, having higher incidence with exercise, long QT type 2, having higher incidence with auditory and sensory stimuli, and then long QT3 having higher rates during sleep. And these are called by potassium or sodium channel mutations. And the long QT treatment presents some special controversies regarding the ICD management. Patients who have never had therapy and are resuscitated from near drowning or other life-threatening event and have not been treated with beta blockers, should we put an ICD or should we try first beta blockers and avoid high-level exercise? Patients who have long QT type 1 with medications, are they taking their medications? Sometimes they're not taking the medicines, and if we can achieve compliance, then we may save them from proceeding with an ICD. Also, the role of left cardiac sympathetic denervation is a significant one prior to putting an ICD in. And finally, males with long QT type 1, they tend to have lower events as they enter adolescence, so we try to proceed with just increasing medications, avoiding triggering events until they're adolescents, and then they may need less, they may have less events, and they may not need an ICD. The high-risk patients with long QT are those who have very long QT with type 1, females with long QT2, and males with long QT3. Zerver-Lange-Nielsen, we talked about. Long QT type 3 patients, we may not have a good way to prevent sudden death. And then there are higher risk mutations like Timothy syndrome, long QT type 8, or calmodulin mutations, which is the most recently identified type of long QT. You can see here an example of that for a patient from a patient of ours who has been identified since neonatal period with very long QT, more than 600 milliseconds, and with very frequent episodes of torsade de pointes, which required multiple resuscitations, multiple shocks while he was in the ICU. Here's another patient with long QT type 1 with Zerver-Lange-Nielsen syndrome that we identified in a toddler by an implantable link monitor that we had placed, and we are now, this is before maximizing his beta blocker, and we're now planning to do sympathectomy and trying to avoid implanting an epicardial ICD in a 3-year-old 12-kilogram patient. So the indications for an ICD in patients with long QT, based on the most recent PACES and HRS guidelines in pediatric patients, are, of course, when there are survivors of sudden cardiac arrest, but there is a consideration for medical therapy and sympathetic denervation if these have not been tried, and of course patients who have episodes while taking beta blockers or when they are ineffective, and then when there is a very high risk mutation or high risk ECG in patients without previous episodes as a primary prevention. ICD should not be clearly implanted in asymptomatic patients who are at low risk. On CPVT, which Dr. Avramidis talked about, this is a rare disease, but it is a very highly lethal disease. Dr. Avramidis talked about this, that this is a disease that presents with exercise or with stress. They have normal QT, but with exercise they can have this polymorphic VT, and then they may also have this bidirectional VT, very classic for CPVT and very other few conditions, and then they can develop ventricular fibrillation. The problems with CPVT are, first of all, there are patients who are high risk, and they do not respond well to beta blockers, even with selective beta blockers. Flecainide is a good drug that may improve the treatment, but patients who have frequent episodes of catecholaminergic VT, they may have inappropriate or ineffective shocks in about 20 to 30% of patients with ICDs. And ICDs may worsen the situation because they just trigger another episode of catecholaminergic VT. So ICD implantation should be reserved for very high-risk patients who have prior sudden cardiac death or sudden cardiac arrest with refractory arrhythmias on combination medical therapy. In many patients, even with aborted sudden death, as with long QT, we may consider first pharmacologic therapy and sympathetic denervation before an ICD. And these are the recent guidelines from PACES, and this just repeats what I just said about the considerations for ICD in catecholaminergic polymorphic VT. Now, Brugada syndrome. Dr. Avramidis mentioned that as well. This is a disease that is most commonly identified in young adult males more than 30 years of age. But we do have pediatric patients and adolescent patients who are identified either during family screening or just incidentally. And we come with a patient that has this ECG of ST segment elevation in leads V1 and V2, and we come with a dilemma of what to do with this patient. He's asymptomatic. He was just identified because there is a family history, because he has fever and he was having an ECG. So Brugada syndrome is caused by several genes, but the most important one is the sodium channel gene, SCN5A. It has this clear characteristic picture. It's provoked by sodium channel blockers, and the triggers of events are also sleep. It can be high fever or a heavy meal, and some substances like alcohol, cocaine, or in adolescents, we often see that with marijuana use. The special issues with children are that the events, of course, are very rare in young children, but there are clearly pediatric patients who are high risk with Brugada, and they often present with atypical ways of sustained monomorphic VT. The good thing is that quinidine, which is an underused drug, may be very effective in delaying ICD therapy in children. And these are the guidelines, which of course are that ICD should be implanted in a patient who is survivor of sudden cardiac death, and it is reasonable for patients who are symptomatic with a spontaneous Brugada ECG and syncope that appears to be of ventricular origin. There are, of course, patients who have neurocardiogenic syncope, and we need to identify those clearly. And then patients may be implanted with an ICD if they have a drug-induced Brugada ECG, but they have clearly dangerous syncope. And the last disease that I would like to talk about is hypertrophic cardiomyopathy, which is, as we know, autosomal dominant disease. It is the most common cardiomyopathy, and it is identified in about 1 in 500 adults, but in children the incidence is lower because the phenotype has not expressed yet, and it may be just in progress. The estimates for sudden cardiac death in childhood hypertrophic cardiomyopathy vary between 1% and 7% per year. Of course, with modern therapies, they are not as common. The risk factors for sudden death in children are similar to the adults with some differences. Syncope is a major one. Non-sustained VT is important. Family history is also important. Now, recent developments in MRI have shown that late gadolinium enhancement and T1 mapping have shown important findings that are maybe associated with ventricular arrhythmias. And there are pediatric studies that have shown other factors that may be used to risk stratify these patients. And as Dr. Avramidis mentioned, there is now a specific HCM risk score developed by the group from Great Ormond Street. This is an example of a late gadolinium enhancement in a patient with hypertrophic cardiomyopathy. You can see some diffuse pattern here in the ventricular septum, which is also very thick, more than 3 centimeters. Even for an adult, this is very thick. And then another way of identifying abnormal fibrosis is with T1 mapping. So in hypertrophic cardiomyopathy, an ICD implantation is indicated in patients with hypertrophic cardiomyopathy who are survivors of sudden cardiac arrest or who have spontaneous sustained VT. For children who have more than one or maybe even with one primary risk factor, consideration should be given for an ICD. It's a class 2A indication. If they have unexplained syncope, massive left ventricular hypertrophy, non-sustained VT, and family history. And then an ICD should be considered even in patients with not clear-cut indications from the above list, but if they have extensive fibrosis on MRI. So, in conclusion, defibrillators in children under 16 years of age, are they not necessary or underused? It's clear that guidelines written for adults should not be automatically translated to children. Technical issues and complications are more common in young children. And many children can be managed with non-invasive measures at least for several years. However, when necessary, ICDs can be implanted in children, even in infants. And so the answer is the implantation is often not necessary, but perhaps it is underused. Thank you very much for your attention.